Okay, guys, we're going to go ahead and get started since we've got a big lecture today and people want me to go over the quiz. So, good, got him. All right, so a little business before we start on the quiz. Just remember when you do your OB clinicals with me in the hospital and you submit your paperwork, I do not need a reflection. Okay? Do not need a reflection. Okay, just the care plan and the log. And as far as the exam's concerned, I sent that frantic email to you guys last week because I know I said something to my PMs about their exam and then I was afraid I said something to you guys that was incorrect. The exam is after lecture today. Do you see the thing on week 4? So that might have confused some of you. I have to put it somewhere. Maybe it would have been better for me to put it in week 5 because the exam is going to open on Tuesday, which is week 5, right? So would you prefer I do that so you guys don't freak out?
Can we actually have a discussion about that?
What?
Because we actually have 2 additional exams next week.
Okay.
One of which is the same, would be Tuesday, Wednesday.
Okay.
So would you guys be opposed to having it Monday, Tuesday, or Sunday, Monday, so that we're not trying to hammer out 2 exams in one day?
I'd be
Monday. Monday works for me too.
Yeah.
Monday, Tuesday.
I would actually, I'm sorry, I have clinicals on Monday with you, and so being on Monday, it's kind of
I think Sunday, Monday.
Sunday, Monday. I think
Yeah.
both Monday and Tuesday.
Now, do you just want it for this exam or do you want it for every?
just for this
Okay.
exam.
So Sunday and what time?
6 p.m. Does that work?
That works.
6 to 6, 4 to 4.
4 p.m.
So I work all day Sunday, so it won't be till Monday.
4 to 4.
Yeah.
Okay.
4 p.m. to 4 p.m.
So it's going to open Sunday at 4 p.m.
Cool.
Okay.
Thank you.
You're welcome. The OB project, please don't confuse the OB project with the CUSUM project. They're 2 different projects. 11 of you have signed up for a topic in the middle. There's a choice option. You can sign up for a topic. I'm just mentioning it because I don't want the other 7 of you to forget. Okay. It's not a requirement that you sign up for the topic. I don't care what topic you do. I just want to make sure that the 7 of you didn't forget. Okay? And then,
When's that?
huh?
When's that coming up?
So it's due, does anybody remember when it's due?
March 23rd.
March 23rd. It says it in there when it's due. I just don't remember off my head. Also remember, because of the ASIN visit, and they need to sit in on a class, an RN class, they picked us. So Tuesday, the time that they have scheduled to listen to a class is on Tuesday, which our class is not. So we need to move our class, well, not move, because we're still going to have class on Thursday. Tuesday, March 15th, we will have a class at 10 o'clock from 10 to 10:50. Okay, that's only 50 minutes, so I need another 50 minutes with you guys. So we're still going to meet on Thursday, the 17th, but we're not going to meet till 9:10. Okay? 9:10 to 10.
So on Tuesday, is that starting on the hour at 10?
That is starting at 10.
Okay.
Now, the hybrid people, of course, they have the option of coming or not coming, but the more of you that come, the happier ASIN will be. Okay? So I would appreciate it if you all were able to attend.
And that's Tuesday, March 15th.
Tuesday, March 15th. And then your ATI proctored exam has been scheduled for March 24th at 2:10 p.m. to 3:30 p.m. in AD 17.
Can you say that one more time?
Thursday, March 24th at 2:10 p.m. to 3:30 p.m. in AD 17.
Okay. Any other business you guys want to talk about? We're going to review the exam really quick. Telephone triage nurse gets a call from a postpartum patient who is concerned about jaundice. The patient's newborn is 37 hours old. What data should the nurse gather first? Should the nurse gather a bilirubin level? Should the nurse gather information about fluid intake? Should the nurse gather information about skin color and about stool characteristics? What's the answer?
Skin color.
Skin color. Should she ask about the other things?
Yeah.
Yeah. But the first thing she wants to know is skin color. Because if the baby's not looking orange, then probably is not a problem. So, but then she can still ask about the other things. And if the baby is looking orange, then yeah, she wants a bilirubin level, but she can't get that over the phone with the patient. So, skin color was the correct answer. During post-conference, nursing students are simulating physical assessment of the newborn using a model. Throughout the simulation assessment, students describe each of their actions. Which nursing student's statement indicates the need for further teaching? I obtained the infant's fetal heart rate by observing the cardiac monitor. Does anybody doubt that answer? Okay. For one thing, you're doing an assessment, so the monitor probably is not on, but even if it were on, your assessment is based on your assessment of the patient, not your assessment of the monitor. So yes, you can use that monitor for surveillance during your shift or during your care, for quick surveillance. But when you're doing assessment, you need to assess the patient, okay? All right. The nurse assesses 4 newborns. Which of the following assessment findings would place a newborn at risk for developing physiologic jaundice? Mongolian spot, cephalohematoma, telangiectatic nevi, or molding?
Cephalohematoma.
Hematoma. Anybody have a question about that?
What's the third one?
It's a birthmark. Okay.
That's Mongolian.
Mongolian spot is also a birthmark, pretty much, on those type of babies. We'll talk about that today.
For the supplemental, why was that again?
So, jaundice is the breakdown of red blood cells, okay? And a hematoma is blood cells. And so, to break all those extra blood cells down puts a baby at risk for jaundice. Okay? The nurse attempts to elicit a Moro reflex on a newborn and assesses movement of the right arm only. Based on this finding, the nurse immediately assesses Babinski reflex, Ortolani's maneuver, the clavicle, or Gallant reflex. Clavicle, why? Right. So they're not, something's happening with the left arm that they're not,
Would feet be moving too
Huh?
with a Moro response? Like
Yeah.
what you want to see. So why not?
because it's saying that the, well, yeah.
I was thinking like maybe hip dysplasia. So
Oh.
if the feet aren't moving either. All right.
Sorry, that could kind of, I could see how that can screw you up a little bit. But even with a dislocated hip, you might see feet movement, but you might not see a big leg movement.
She didn't
There
want
was
to clap.
one of the tests in there, not the Galant or whatever, it started with an O or something. I
That's-
couldn't find that in there. Could you find it?
Yeah, well,
It's for hips.
I think I might have a picture of it, but nurses don't typically do that maneuver. It's usually the physicians, and they're, manipulating the hip joint. Okay, last one. The nurse has received an end of shift report on a postpartum unit. Which patient should she see first? Primip, first postpartum day, hypoactive bowel sounds, all quadrants. Multip, second day post-cesarean, moderate lochia serosa. Primip, day of delivery, fundus firm, 2 centimeters above the umbilicus.
Bladder just.
Or it could be extra blood pooling.
It could be blood pooling, or it could be a full bladder, which,
The thing that I had a hard time with deciding that is like when you're reading the book or looking at slides, it says 6 to 12 hours after birth.
Yeah.
So it's like, where are we in that?
Oh, well, you mean as far as, what's the question? Wait a minute, let me look again.
It seems like could 2 centimeters
Prime
also
im-
be a
prime im-
normal finding, so it wasn't.
Day of delivery, fundus 2 above. Fundus should never be 2 above any day of delivery. I mean, it can't, you will find a fundus that is 2 above, but normal funduses should never be above the umbilicus after delivery. So, yeah, she may have a full bladder, and then she empties her bladder, and then that fundus comes down. Easy peasy. But more importantly, she could be bleeding and filling up her uterus. Okay? All right, so that's that. Okay. All right, so we have a big lecture today. Uh-oh. Oh, yeah, absolutely. So I'm going to go pretty quick through this lecture. Please stop me if something is confusing or if I went too fast. I will slow down and try to be more clear about that topic, okay? Deal. Physiological responses, so respiratory, cardio, and there's a whole lot other newborn responses, but I'm going to go over respiratory and cardiac here a little more in depth. So normally, the baby in the last part of trimester is producing a lot of lung fluid to now make these lungs expand, to get to a normal lung expansion size by delivery. But a couple of days before labor starts, the fluid diminishes, okay? And that's because we don't want babies born with a lung full of fluid. But there's still a little bit remaining, okay? So during the birth process, the chest is compressed and squeezed, and a little bit of fluid is squeezed out, okay? But not enough. And then as baby is delivered, those lungs were compressed, and now baby takes a big breath or cries, okay? That creates intrathoracic pressure, which helps distribute the lung fluid over the capillaries, and then that fluid can be absorbed, okay? With inspiration, there's a negative pressure in the lungs because the diaphragm drops a little bit with that big inspiration. And then that kind of opens up all the areas around the alveoli. And then the fluid goes to the interstitial and can get absorbed by the blood flow, okay? Now also with the first breath, it's also triggered by, so there's an increased PCO2, decreased pH, and decreased O2, which is kind of a normal asphyxiated state for a newborn. And that's because the cord is clamped, so all those gas exchanges aren't happening through the placenta now, okay? They're building up in baby's blood system now, which stimulates baby to breathe, okay? And then also, those changes trigger the receptors, the aortic and carotid chemoreceptors, which then send the signal back to the brain. We need to start breathing, okay? Now, there's other things that stimulate baby to breathe besides those things. So baby is in a nice warm environment in utero, and now baby is born wet into a cold environment, okay? So that stimulates nerve endings in the skin, and then that goes back to the brain center and says, let's breathe, okay? If that continues, if that baby isn't dried and warmed, then the opposite effect happens, okay? But we're talking about normal effects right now. So the intrauterine, what?
So hypothermia will
Prolonged or continued, okay?
Hypothermia.
Yeah, hypo. Okay, so the intrauterine environment is dark, it's warm, sound is dampened, it's a weightless environment. Now baby's born, there's lights, there's noises, baby is feeling the effects of gravity, and then people are touching and talking and doing all these things which kind of also help baby to decide to breathe. So behind the scenes, these are the kind of things that are happening. So as the baby takes a breath, that increases the PO2, okay, right? Everybody agree that's what happens when we breathe. We increase our oxygen, okay? That decreases the pulmonary vascular resistance. And if you remember in fetal circulation, there's a high pulmonary vascular resistance because blood is not really going to the lung to be oxygenated. There's just a little bit of blood going to the lung just to feed the lung. That's it, okay? So that's why the pulmonary vascular has a higher resistance, okay? Now that the cord is cut and we need blood to now shunt into the lung to get oxygenated, we need to decrease our pulmonary resistance. So when we take that first breath, that's what it does. It increases blood flow to the pulmonary, to the lungs, and then there's an increased pressure in the left atrium, okay? And this causes that foraminal valley, or that little duct in the right atrium, to close, okay? Now, we also, with that first breath and increased PO2, we also increase our systemic vascular resistance, okay?
Really quick, sorry. The pressure in the left atrium causes the closure of the foramen?
Right,
Okay.
right.
Okay.
All right, so the increased vascular resistance is now causing that the venous return to be decreased, okay, back to the heart, and then the cessation of umbilical venous return. So through the liver, where that ductus venosus is, okay, so that causes it to close, all right? Now also with the increased systemic vascular resistance, the closure of the ductus arteriosus, that's the one in the aorta. That's what causes the one in the aorta to close. All right? So, that's all really easy to understand, right? So, in fetal circulation, we're just switching our pressures, okay? And because of those pressure shifts, those ducts are supposed to close. Okay? So if baby has a problem oxygenating, baby is not increasing their PO2 levels for whatever reason. They're not breathing well. They're not having good, maybe they're breathing, but they're not getting good oxygen exchange because there's still a lot of fluid on those alveoli. We're not going to create these pressures, okay? So those ducts aren't going to close. And that kind of puts that baby in a persistent fetal circulation. So baby continues to shunt through the ductus arteriosus. Therefore, that blood is not going to the lungs to get oxygenated. Okay?
I must have glossed over the ductus venosus. What's the function of that during the fetal circulation?
Okay, so when the blood enters the baby through the umbilical vein, okay, and it travels up to the heart, some of it shunts over into the liver. It all shunts over to the liver, and some feeds the liver, and then it passes. Then it goes to the right atrium. Okay, and now that it doesn't have to shunt that way, it can go. Their systemic return can go straight to the vena cava. Okay, that creates the pressure to close ductus venosus in the liver.
And what's the purpose? Is that, it's just an extra filtering mechanism while they're in fetal circulation? Or?
Well, the blood has to go through the liver, okay, from the placenta, from the umbilical cord, and then go up to the heart, okay? So it has to, that's the way it feeds the liver, and that's the way the baby's able to process things, filter things through the liver, okay? It doesn't need to have that pathway from the umbilical vein anymore. So it can go straight now to the vena cava. The important thing I want you to know about this is if baby is not oxygenating well, that ductus arteriosus is not going to close, that foraminal valley is not going to close, so blood is not going to shunt to the lungs like it's supposed to, like our circulation does. Therefore, baby is not getting oxygenated through the lungs, okay? That's the important thing to know about this whole deal.
If you have one of those that's in the heart not closed, is that going to be really audible as like a murmur?
You could possibly hear the murmur. Now, I've had a pediatric cardiologist tell me the quieter the murmur, the larger the hole. Okay? And as that hole starts to close and the turbulence is a little restricted now, then you hear the murmur more. So like if you're taking care of a baby in the hospital for a couple of days and you vaguely hear a murmur, you know, that first day, and as the day progresses, maybe that murmur gets louder and louder, you almost can assume that the duct is closing. Almost. It's not always the case, but it's just kind of a quick screening assessment parameter.
Are you going to see like a decrease in cyanosis then? And there are going to be other signs?
If it closes, yeah, I mean, if baby had a huge patency, and you were seeing cyanosis because of that, if the duct starts closing, yes, you are definitely going to start seeing that cyanosis improve.
That test we did in that newborn assessment room where you put the pre and post.
Okay, so we do an assessment pre and post ductal saturations on babies about 24 hours after birth. And the results of that is if the baby fails that test, then we know something is wrong with the heart. Okay, either baby's still got patent ducts or there's a congenital heart defect. Okay, and so what we do is we look at post-ductal saturations and pre-ductal saturations, and they're talking about the ductus arteriosus, so on the aorta. So for pre-ductal, what part of the body is being fed oxygenated blood before the duct? Okay, and the only part is the right arm. So that's your pre-ductal saturation, okay? The post-ductal saturation is the part of the body that is being fed after the duct in the aorta, okay? And that's definitely your legs, okay? And sometimes, depending on where that vessel is that comes off and feeds the upper left side, if it happens to fall close to the duct or before or after. So the left arm is usually a post-ductal saturation, usually, but the safest is to get your post-ductal on the legs. So the saturations need to be above 95%, and they need to be within 3 percentage points of each other. So if my right arm was 92 and my post-ductal was 98, one, my right arm is not above 95, and two, that's greater than 3%. So baby needs some follow-up studies. Okay? All right. So I didn't put any slides on blood values for the newborn. most of the time, if a normal newborn is getting blood work done, it'll be a hemoglobin, or I'm sorry, a hematocrit, okay? And I want you to know what the normal values for hematocrit are. I'm not sure what the text says. It's going to be somewhere between 40 and 70.
43 to 63.
Okay. So remember that for the exam. Okay. I'm not going to tell you what real life is. It doesn't matter. Just remember that for the exam. Okay. Because.
Only hematocrit?
Huh?
Only hematocrit?
Well, usually they just do a hematocrit because that's the one they're more concerned about as far as blood volume, anemia, or dehydration. If they're really concerned about an anemia problem, they'll throw in the hemoglobin. But most often, if they're doing that, they're just doing the crit most often. So that's the one, hint, hint, I want you to know for your exam. Okay?
43 to 63.
Okay, thermogenesis. We're going to talk about thermogenesis because baby's temperature is really important. It's a huge deal, and cold babies can spiral and get very sick just because they're cold. They could have no other issues. They could be a normal, healthy newborn, and if you let your baby get cold, you're going to create problems for your baby, okay? And possibly enough problems where baby needs to be admitted to the NICU and put on sugar water, okay? So, or maybe even oxygen. So, temperatures are really important for baby. So, in a normal baby, they keep themselves warm by thermogenesis. Okay, that means they increase their metabolic rate. Their O2 consumption. So, if they're a little cold, they might start breathing a little faster, get a little more oxygen, and then muscular activity and non-shivering thermogenesis. And non-shivering thermogenesis is because babies don't typically shiver, okay? Their sympathetic nervous system is just not mature enough to shiver to create temperature. So if a baby does happen to shiver, it's not doing what it does for us when we shiver, okay? So this non-shivering thermogenesis occurs when the baby's skin receptors perceive a drop in environmental temp, okay? And so what it does is it uses baby's brown fat stores to create heat, okay? So we shiver to create heat, and babies use brown fat metabolism to create heat. So this brown fat, it starts to accumulate between 26 and 30 weeks, okay? And it continues to increase till about 3 to 5 weeks after birth. It's found in the mid-scapular areas, around the neck, the axillas, around the trachea, esophagus, abdominal artery, kidney, and the adrenal glands, okay? Brown fat is dark, that's why they call it brown, because it's rich in blood supply. It has a lot of dense cellular contents and abundant nerve endings, okay? And this is why, those characteristics are why they're able to metabolize this differently than just regular fat to produce heat. All right.
The baby burns this fat in order to increase body temperature.
Mm-hmm. Now, here are the ways that babies lose heat. Okay, evaporation, which is losing heat. A wet baby, the wetness evaporating off of the baby's skin will cause baby to cool off. Okay, so important that when babies are born, we dry these babies like crazy. Okay. And then if you give a baby a bath, like you do it in a warm environment, and you dry these babies very quickly. Convection, losing heat with cool air. So like the air conditioning's on, or maybe there's a breeze in the room, and baby's skin is exposed. Radiation is the loss of heat from a cold object that is nearby. So you've got your baby in the bassinet, and baby's not wrapped, and the plastic sides of the bassinet are cold. So that will pull heat from the baby. And then conduction, they're losing heat because baby is touching a cold surface. So you put the baby on the scale to weigh the baby. The scale is either metal or plastic, and it's cold. And you lay the baby on there, and baby's going to lose heat to that surface. Even your stethoscopes. So before you listen to babies, you know, rub your stethoscope. Before you touch your babies, rub your hands, okay, if you're a cold-handed person.
So the only difference between the radiation and conduction is that radiation is a little further away.
Yeah, they're not touching the object, okay? So they could be on a warm blanket, but the sides of the bassinet or something are cold. And that cold sides will pull the warmth off the baby. And here's just a picture of, kind of a picture of how all that stuff happens. All right, so so babies are born. The physician might wipe them real quick, but then they go straight to mom's skin. And then we dry the baby on mom's skin, and then we cover baby up with a warm blanket. And so you all know that skin-to-skin contact, like if you're freezing in the winter, strip down and snuggle up to someone you love or don't love, and you'll get warm, okay? Okay, any questions before we go on to bilirubin? Huh?
How do I increase my brain?
Yeah, you won't do that anymore, ever again. Okay, bilirubin is the product of red blood cell breakdown. Okay, it's a yellow lipidy goo. Okay, and that's what makes the baby's skin yellow, is an accumulation of the bilirubin, and until it gets excreted out of the baby's system, then you'll see it in their skin tissue. And usually, you see, it kind of goes from head to toe. So you see this baby, and their face is a little orange, okay? And then a couple hours later, you come back, and now that orange is down their neck and to their chest. And then a couple hours later, and so forth and so on, okay? Now, conjugation is the process of changing the bilirubin into an excretable form. It's water soluble. Unconjugated bilirubin is fat soluble, and it's stored in the fatty tissue, and it's not excretable. So the more we store, then that becomes toxic at high levels, okay? Now, total bilirubin is just the sum of both. So, and they also say, you also hear direct bilirubin, you'll hear indirect bilirubin, okay? So direct bilirubin is conjugated, indirect is unconjugated. So the best way to remember this, if you feel you're going to have trouble remembering this, is conjugated doesn't have a prefix, neither does direct, and unconjugated has a prefix, and so does indirect. Okay? Now, when baby was in utero, any bilirubin that baby had was excreted in the placenta, or crosses the placenta and was excreted by mom, okay? But after birth, now baby has to do it all himself, and conjugation occurs in the liver. So baby's liver has got to do this work, okay? Now what happens when bilirubin is, okay, so we break down some hemoglobin, it's floating around in our blood, and it binds to albumin. And then albumin drives it to the liver. And then, don't even dare ask me to say this word, but this UDGPT enzyme takes this bilirubin that came to the liver, and it attaches it to this glycuronic acid. And basically, now we have conjugated or direct bilirubin. Okay? Now this conjugated bilirubin now is transported into the intestines. Okay? And then in the intestines, some of the bacteria in the gut take this conjugated bilirubin and transform it into either uro or stercobilin, okay? And that's how it's excreted. The urobilin is excreted in the urine. The stercobilin is excreted in the stool, okay?
Wendy, for the test, how in depth on the conjugation of bilirubin are we going to get?
Okay, so I'm not going to ask you these specific transporters. I'm not going to ask you about UDGP. I want you to know that conjugation happens in the liver, okay? That before it gets to the liver, it's unconjugated and cannot be excreted, okay? Once in the liver, it gets conjugated and then transported to the intestines to be excreted, okay?
Does that affect the color of the feces?
Yeah.
No, brown.
All right,
So if,
go ahead.
maybe you're gonna talk about this, but if it's not excreted, the text talks about that it can get reconverted.
Right.
Where does that happen?
Okay, that happens in the intestine. Okay, so we've got our conjugated bilirubin in there, and whatever bilirubin did not get changed to uro or stercobilin gets converted back, changed back to unconjugated bilirubin in the intestine, okay? It's this beta D word, okay? I'm not going to test you on the words. Just know that, so if bilirubin isn't excreted, okay, so in the intestines, now it becomes unconjugated, and now it's going to head back to the liver, okay? When that happens, that's where we see our increase in jaundice or bilirubin in the blood, hyperbilirubinemia. Okay? So not only are we unconjugating bilirubin in the intestines and sending it back to the liver, all the unconjugated bilirubin that was in the blood that hasn't gone through this process yet is now also going to the liver. And this is where the liver gets overwhelmed, and then we get the high blood level of bilirubin, okay? And we will talk about all the reasons why this can happen.
I'm not understanding, so it's in the intestine, it's already converted, why is it changing, what's signaling it
Okay,
to go back?
so most of it is converted, not all of it. So whatever few remaining pieces don't get converted, depending on how much of that,
Can it leave the
Yeah.
liver as unconjugated bilirubin?
well, it can be back into the blood system, but it can't leave the body. Okay? Back to your question. So all that conjugated bilirubin went to the intestines, and then it became uro and sterco, right? Not all of it became that, okay? And then what's remaining in there is now this beta D word is going to unconjugate it and send it back.
So it's just hanging out in the intestines just because
Right.
it hasn't been.
Because we have to have enough of, let me go back so I don't totally sound like an idiot. We have to have enough of this UDGPT to handle the conjugated load. If we don't have enough to handle the load, then we've got some left over. Okay? All right. Now where am I at? Okay, so we went back to the liver. Now, so there's a couple of different kinds of jaundice. There's the physiologic jaundice, which is mostly the one, well, not mostly. So it occurs in 50% of term newborns and 80% of preterm newborns. And I don't know how old this statistic is, but I think it's shy. Because it's pretty normal for babies to have some level of jaundice when we discharge them, but not necessarily enough to treat them, okay? So a lot of babies go home with jaundice, okay? Now, the reason why we develop jaundice is because we're breaking down a lot of red blood cells, okay? Which is a normal process and just a normal birth. But if we add birth trauma onto it, or some type of ABO incompatibility, then we're going to have more red blood cell breakdown, okay? And then if we have any impairment in the conjugation process, okay, and then we also reabsorb more because of that load in the intestine. Maybe it's too much of a load, okay?
So the load that is in the intestine that becomes the recycled portion is actually unconjugated from
Yeah,
the
because
liver.
it'll break down, that beta D will break it down from its conjugated form
Okay.
because it came to the intestine conjugated, right? So in the liver is where it got conjugated by the UGDPP, okay? And then it goes to the intestine. So it's conjugated in the intestine, okay?
Okay, hold on. So I thought it came to the liver unconjugated.
It goes to the liver unconjugated. It binds with albumin, albumin takes it to the liver. In the liver, it gets conjugated.
Right.
And then it goes to the intestine.
Okay.
And
And the
then-
stuff that's in the intestine that gets reabsorbed is conjugated, or it's unconjugated because there was not enough of it?
It was conjugated when it got there, and then in the intestine, it gets unconjugated and sent back to the liver. Unconjugated bilirubin is what causes jaundice. Okay?
I just thought maybe the stuff the extra stuff from the enzyme gets shoved into the intestine as unconjugated and then is put back into
No.
the system.
No.
So it's all still
Yeah.
conjugated.
So it's conjugated, okay? So let's go back. Let's just go back. So it's conjugated, okay? UDGPT in the liver conjugates it and sends it to the intestine, okay? And then bacteria in the intestine change that conjugated bilirubin into this uro and stercobilinogen, which is now excretable, okay? But if there's too much, conjugated bilirubin coming to the intestine, overloads the process of changing it to the excretable form.
Okay.
We still have a bucket of conjugated bilirubin. Now this beta D unconjugates it so we can send it back to the
I got you now.
liver. So just make it simple. Just make it simple, okay? Because I'm not going to ask you about these enzymes and who does what where. Conjugated bilirubin goes to the intestine. It gets transformed into an excretable form to be peed out or stooled out. And then what's left over gets unconjugated and goes back to the liver. And now we have too much unconjugated bilirubin, and that's going to cause jaundice.
So is that due to a lack of albumin then, as it goes back?
We're going to get there. We're going to get there. It could either be a lack of albumin, or there's a fatty acid in breast milk that competes for albumin. So if all these fatty acids, grab up all the albumin, then the bilirubin can't bind to it, and the bilirubin can't get to the liver. So it just remains in the circulation. Okay, but that's one of the mechanisms. Okay, so we've got an increased destruction of red blood cells. We've got impaired conjugation of bilirubin, and then we've got the increased reabsorption. So in other words, back into the liver.
And you're saying that 50 to 80% of newborns are going to develop this jaundice. How long does that take? Are you going to see it?
You can see it within the first 12 hours. Okay, and it's 50% of newborns and 80% of preterms.
Right, and it's going to get progressively worse in that 12 hours? And then
It can get
12 hours?
it can continue to get progressively worse. Okay, and we'll talk about that here in just a minute. Okay.
The newborn isn't going to come out yellow.
No, because in fetal life, all the bilirubin was crossed through the placenta. So when babies are born, they don't have bilirubin problems at all. Okay, these develop. Okay. All right.
So physiological jaundice just means they're a baby with jaundice. That's all.
Well, pretty much. Yeah.
Okay.
Okay. They broke down a few more red blood cells. They're reabsorbing more because of an overload, or they're not getting conjugated in the liver to get excreted.
Okay, so if they had a completely unfunctional liver, is that still considered physiological jaundice?
No, that will be pathologic.
Okay.
Okay. Now, pathologic jaundice. So we have increased amounts of bilirubin being delivered to the liver. Okay. We could have that increased amount because of delay in cord clamping, so there's a lot more blood getting back to baby, a faster red blood cell destruction, or a forceps or a vacuum extraction can be created, can create more bilirubin. Okay, so we've got all this going back to the liver, and then so that causes that bilirubin, too much bilirubin to be conjugated. Okay, so a lot of it is staying unconjugated, and then we have another thing we have is we're not getting the bilirubin out of the blood system. Okay, so we have bilirubin staying in the blood, not going to the liver. Okay. And so we either got decreased calorie intake, so we're not able to produce enough albumin, we're not able to increase the blood flow, and then we're not able to bind. So this is where our albumin binding problem comes, okay? And then in the liver, if the bilirubin gets to the liver, then our UDPGT is decreased for some reason. There's a problem with that enzyme, okay? And also, another pathological reason is the baby could have some sort of infection that inhibits this process in some way, or the intestinal flora, which is where the intestinal flora is what changes the conjugated bilirubin into the excretable form. Okay, so we don't have enough intestinal flora to do that. And then we have more going back to the liver, and we might have reduced bowel motility for some sort of gut problem, a preterm problem with the gut. There's an obstruction, or we're not passing stool, so we're getting kind of a blockage from the stool.
Wait, I have a question. So with the physiologic jaundice, it basically happened because of the trauma from birth and just from physically the red blood cells being damaged, whereas the pathologic jaundice is any part of that chain of the conjugation, unconjugation being impaired?
Right.
Okay.
And as far as the exam's concerned, I don't really care if it's physiologic or pathologic, because the treatment is going to be the same. So as far as an exam's concerned, I'm not going to ask you to tell me which it is. Okay? Now, there's also breastfeeding jaundice and breast milk jaundice. Two different things. Okay? So if we think it's breastfeeding jaundice, then our culprit is poor feeding practices. So instead of saying breastfeeding jaundice, we could just say feeding jaundice. Because if they're not feeding enough formula, this could be a problem, but that's never the problem. They never don't feed enough formula. They always probably feed too much formula. Breast feeding is usually the culprit because of the low breastfeeding volume, the difficulty in establishing breastfeeding, so they're not getting large volumes from these feeds. Okay? So poor feeding practices or poor breastfeeding practices. So, breast milk jaundice, different than breastfeeding jaundice. Breast milk jaundice is more about the milk, okay? So this is where the fatty acids in the breast milk competes with the bilirubin for binding sites on the albumin to even start the process to get to the liver. So, they have jaundice. It's one of the four. Okay. They have jaundice. It's one of the four. I don't care what four it is. I don't care if it's breast milk or breastfeeding jaundice. We need to increase the breastfeeding. Okay? So, the more the baby eats, the more the baby can start that whole process of binding to the albumin, going through the liver, and all that kind of stuff. Now, the less the baby eats, okay, the less that the bilirubin is going to be able to bind and go through that whole process. Now, as bilirubin increases in the blood system, it causes what's called hyperbilirubinemia. It causes sedation, okay? It causes poor urine and stool output because they're not taking in the volume to produce the urine and stool. Therefore, it's not getting excreted, so it's staying in the system, and then it's making them more lethargic, so it's making it harder to wake them and feed them, and it's a vicious cycle. So the bilirubin will keep increasing and keep increasing. When it gets to toxic levels, this can cause irreversible brain damage. Okay, so we test these babies at 24 hours of age and then every 24 hours as long as they're in the hospital. And then if it's abnormal, we will continue to test them at a certain interval. But what we see with bilirubin, and I'm sorry I didn't put this graph on there, but I'll show it to you when we're in clinicals, is we have a graph, and it's a curved graph, okay? And it has a 95 percentile and a 10 percentile, I think. But we'll look at the graph. And then, so on the y-axis, the vertical axis, is that y?
Yeah.
Right? Is the bilirubin levels, or the results, okay? On the x-axis is the baby's age in hours, okay? So as baby ages on this graph with 10 to 95%, the baby's bilirubin can be higher the older they are, and it still be normal, okay? So if baby had a bilirubin of, let's say, 8 at 24 hours of age, that, I'm not sure, but that could probably fall in the normal parameters. But if baby had 8 at 12 hours old, then baby's starting to fall above the parameters. So we'll look at that graph. I thought I put it on here, but I didn't.
I have one quick question. Why is it that they say that to put babies in natural light if they have...
In what?
In natural light when they have jaundice? Right?
Okay, so light is what breaks down bilirubin in the skin. Okay? So, so with these babies that we're worrying about jaundice, we want to feed them often and keep track of their output, okay? And then if their levels are abnormal, then their treatment is what they call bili lights, okay? So, and what we do these days is it's a blanket with a light in it that folds around the baby, okay? It used to be a bank of lights that we turned on right above the baby, but now it's a blanket that we wrap baby in, okay? And that light breaks down the bilirubin. So if your baby's not abnormal, the levels aren't abnormal, and we don't need to treat your baby, but your baby is a little bit jaundiced, we say when you get home, put your baby in front of a window so the sun can come in and start breaking down that bilirubin in the skin.
Why don't they do that with adults?
I don't know. I don't know about adults. What do they do with adults?
Oh, I don't know. They put them on dialysis.
Oh.
So is the checking at 24 hours, that's something that they just started implementing doing? Because I know when I had my son at community, I kept telling the nurse, and I had a C-section, so I was in there for 5 days, and I kept saying, he looks jaundiced to me, he looks jaundiced. And when they finally tested him on day 3, his bili level was 22.
Oh my God. So that's really high.
It was really high. And I was so pissed because I'd been telling and he was like, oh, she's a new mom, because he didn't look, but I could start seeing it in his eyes, and he was jaundiced for almost 5 months before it finally cleared the sclera.
So your child is older, right?
Yeah. And
So-
to this day, sometimes I wonder, does he really have autism, or was there some sort of neurological damage? And with the second, when I had my second baby, they said it was because I had blood, I mentioned this last week in class, but I had blood transfusions, and there was some sort of antibody, and they said every baby would subsequently be more jaundiced. So with my daughter, they just immediately started treating her.
So, I mean, I know we've been doing it for 5 years. That's when I can remember it started. Yeah, that's when I remember that it started, at least here. That's part of our standard of care for babies at 24 hours. So around 5 years. I mean, I don't know about other facilities, but it's been about 5 years. Because it's so easily treated if you stay on top of it.
Yeah, and then you end up being in the NICU for...
Yeah, and it's devastating if you're not on top of it and you miss, because bilirubin just increases, and
aside from the diet, what other treatments are there for reducing the bilirubin?
Well, they can, so if we have a baby that we're breastfeeding and underbelly lights and we're still not getting the numbers to come down, we may try to start bottle feeding so we get more volume, okay, as opposed to breastfeeding. We may start an IV and just run regular fluid to create more volume.
How does more volume help?
Well, it helps flush out the system. So they have urine to excrete, they have stool to excrete, okay?
Is that why the intestines are reabsorbing it? Because they don't have any stool
Well,
to take it?
yeah, so if we're delaying passing our meconium, that stercobilinogen is just sitting there in the intestine, okay? And if it's not excreted, you know, it's possible that that can be then converted again and then reabsorbed back into the system, okay? Delayed, so delay of passing a stool or decreased motility, movement in the intestines, okay?
So
That can
once
be-
it's conjugated, it can bind to urine and stool. Like there's
Uh-huh.
no other process that needs to change in order for it to be able to pass out. Like it's conjugated, it can go.
So once it's conjugated and get into the intestines, then that beta D stuff, right, so then the bacterial flora in the intestines changes it to the excretable form, and then yeah, it can go.
So conjugated, it's not.
So it doesn't just, the conjugated bilirubin just doesn't come to the intestine and then shoot out. Okay, it gets excreted either into the it gets changed into the uro or the stercobilinogen, and then it'll either go out through the urine or out through the stool.
Okay.
So if it stays conjugated in the intestine, then that beta D enzyme will break it down and make it unconjugated and send it back to the liver.
Okay.
So it needs to be transformed into that uro or sterco to be excreted. If it doesn't get changed to that, then that beta D enzyme will deconjugate it and send it back to the liver.
What binds it in the urine? That weird acronym binds it in the intestines, or the bacteria help turn it. But what decides if it goes into the urine?
So whatever enzyme process, that's too patho for me.
Is that just in the kidneys now? Like,
Well, it's
more
into the intestines, and then the uro is sent to the kidneys to be excreted in the urine.
Oh, so the intestines still are the ones that
Yeah.
alter it.
Right.
They-
No, it's already
For the urine?
from the intestine. It's transformed into the urobilinogen, sent
Okay.
to the kidneys, and then excreted.
Okay. But
Okay.
the intestines do it for both.
Right. Nothing changes in the kidney.
Okay.
Okay. So the only thing, so make sure you, on these sections that I don't actually say something about, make sure you read these sections or are aware of what information is in there. So that was on the GI and the liver. Here is a section on kidneys and fluid balance. Okay. Immunology with the newborn. So your neuro assessment on the newborn. Basically, you're just assessing all those reflexes. Okay, we'll go over those here in a little bit. Behavioral states of the newborn, look over that. Okay, and then if you have any questions about those things after you read them, please let me know.
I have a question.
Email me or call me.
I don't mean to beat the bilirubin like a dead horse, but it said in the book about breast milk jaundice
Mhm.
and stopping breast milk for like 1 day. So are you going to put the infant on formula just for like that 1 day? And
Well, you would, but
Okay.
we don't do that.
You wouldn't do that.
Well, so for your exam, if that's a possible, not on my exam, if that's an exam on NCLEX, breast milk jaundice,
Just stop it for a little bit.
stop it for a little bit, and then resume later. But yeah, they would use formula.
Like from there on out, or just
Until they feel like the breast milk jaundice problem has been resolved,
Okay.
and then come back.
Okay.
But we don't do that in the hospital. All right. So assessment of the newborn. Oh, darn it. So, you will do a normal head-to-toe assessment, but there is a specific physical and neuromuscular assessment that we do that just estimates baby's gestational age. Okay? It's something that we used to do on every baby all the time. But anymore, in real practice, we don't do it all that much unless we have questions about baby's gestational age. So if we had a baby born that by dates or physician's record, this baby was supposed to be 40 weeks, and this baby came out not acting like 40 weeks, we could do this assessment and get an estimation of what the baby's physical findings tell us. Okay? So there's physical characteristics and there's neurologic characteristics, okay? And then, as everything has to be complicated, so maternal conditions can make this assessment not so accurate. So it's just a screening. It's not something diagnostic that we would do different things, okay? But just keep in mind, if you do an assessment, and you're not getting the same answer as what the dates or the prenatal record says, you could have a problem with dates, or some maternal condition could have skewed baby's development to make these assessment characteristics abnormal. All right, so when we're looking at the physical characteristics, we're looking at the resting posture, the skin, the lanugo, and creases on the soles, as well as breast development, breast tissue.
So with breast tissue,
We're looking for size. The size of the bud. So when you feel it, you feel this little bud. So
if it's larger, they're
if it's
further along gestation.
right, and we'll see how that plots out. So we look at the ear and we look at the genitalias, okay? So here's a resting posture of this baby who is obviously preterm, because preterm babies look like rag dolls. Term babies are all flexed up, okay? So this baby would get a low score on posture. Here's another example. This baby isn't as extended as the previous, but still somewhat extended compared to your term newborn, who's also very squeezably fat. Now, when we look at the soles of the feet, we're looking at the creases, and this is really difficult to see, but the more term the baby is, the more creases they're going to have all over their foot. And the more preterm, the more smooth and shiny that foot looks. Here's another very difficult picture to see, but this baby has really some deep creases here. So, anyways. Here's another. Lots of creases on this baby. All right, so this is a breast bud. You can't tell. So these are fingers. And here's the breast bud. Maybe I should dim the lights. Maybe that will make it a little more helpful. Okay, so we're guesstimating the size of that breast bud, okay? And then depending on what we guesstimate, we'll mark that on the sheet. This person's actually measuring with the tape, but. So on the ear, we're looking at this curve, okay, and then we're looking, we're feeling to feel how firm or soft that is, and how when we squeeze it or fold it, if it folds and then just very slowly returns to normal shape, or if it folds and just bounces right back, okay? Here's another picture. Now you can see this baby. I mean, this baby's got good curve. It's not terrible. But compared to this one just looks more curved, more fully filled out, I guess, in a way. And if we were to squeeze that baby's ears, fold it in half, it would have really instant recoil. All right, here's just them folding that ear. All right, now we look at genitalia. And the one thing that we're looking at in genitalia is the rugae. How much rugae is there? The more rugae there is, the more term the baby is, and the less, the less. Here's another picture. And then on the labias, we're looking, or on the little girl, we're looking at how much does the labia majora cover the labia minora. So the more it covers, the more term she is.
I had a question about these photos. Like, what are we looking at here?
This is a little vulva of a little girl. So these are her labias.
It's just odd coloring.
Yeah, she might be. She might have some sort of Asian or African American or Indian descent.
So that's the menorah on the inside? That.
Whoa.
The
Did I get back to the one you were asking?
Yeah.
Oh, I'm
the
sorry.
black right there
That's
is
the menorah.
Oh, okay.
Okay.
So that's a real. Is that a pre?
So that's more preterm.
That's a pre.
Okay.
Okay.
That's more preterm. Here's your fully term. So it's completely covering.
Is
Okay.
it still black?
Huh?
Would it still be black even full term, like the menorah? Like those
No,
previous
not.
ones were all dark.
Yeah. So it was either a baby of some sort of colored descent, or yeah,
Oh,
because
so that
what?
wouldn't be normal with a Caucasian.
No.
To have that.
Mm. So our neuro assessment, we do this square window assessment where we take the baby's wrist and we fold it in half, and most of us, we can't do that, but in a term baby that will fold completely down, okay? The more preterm they are, the more they're like us. They can't fold that down. So this is a little more term than the previous baby. Okay, here's a good example of a nice term baby.
How far are they pushing?
Huh? Well, you're just bending until you meet resistance. You're not trying to push past the resistance. Okay. What?
Probably 20, 25 pounds.
Yeah. So this is scarf hold. So this is scarf hold. So we take the baby's arm and we wrap it across their chest. Okay. The more we can wrap that arm around that baby's neck like a scarf, the more preterm they are. So the more the baby is, like, that's all the farther I can wrap baby's arm around, the more term they are. Okay, so this is a pretty pretermy type baby. Okay, this is more of what you're going to see on a term baby. Yeah, we can't wrap it over because we can't get past the neck fold. No.
That's why I can't do that anymore.
All right, here's another example of a termish looking scarf sign.
So you're just pulling.
Oh,
until it
there's
kinda
my,
meets resistance?
oh no, that's weight. What?
So you're just kind of pulling until it meets resistance?
Mhm,
And
yeah.
then,
Yeah, you're not trying to get past any resistance. Okay, you're just pulling it where you get resistance, that's where you mark your assessment.
so those preterms, like you're just pulling and that's just.
Yeah, it's just,
keeps
you
going.
could wrap it all the way around the neck like a scarf. This got thrown in there, it's not in the chronological order it should be. I'll come back to this real quick, so don't let me forget it. Oh, wow. I guess I am on this deal. So I do want to show you this scoring sheet. Oh crap, it's not coming up. I mean, it's not coming up on there. What do I need? Shift F. Shift F8. Function F8. Okay, cool. Stop. All right. So here's our posture, okay? We look at our baby. What does our baby most look like? We select that picture. Our square window, which does my baby most look like? The one I didn't have a picture of is called arm recoil. So we hold the baby's arms down like this, and we let go suddenly, and baby's arms, if they're term, should go like this. But if they're not term, so this is the preterm side, this is the term side. So when we let go, we decide where our baby falls. Where are all my pictures? So this is popliteal angle here. We lay baby's thighs on their abdomen, and then we try to straighten their leg. So we're seeing how straight we can get this popliteal angle. Okay? Am I in the way? All right, here is our scarf hold, or scarf sign. And then this other one is similar to the popliteal angle. It's called heel to ear. Heel to ear. So we don't really lay babies' thighs on their abdomen. We kind of lay them to the side and see how close we can get their heels to their ear. So whatever angle we get, we'll select that box. Okay? These boxes are headed with numbers. So we add up our selections, okay? And then we put our score over here. And then we do our neuro assessment. Oh, that was our neuro assessment, sorry. So our physical assessment, now we're looking at the physical characteristics of baby. What does my baby's skin look like? Okay? How much lanugo do I have? Do we know what lanugo is? It's the furry baby, okay? Hairy baby. Mostly you determine this like how much hair is on the back of their shoulders and stuff. Their plantar surface. So how many creases did that foot have? We kind of just try to guess which one looks the best to us. The breast. So we feel that breast bud and we kind of try to guesstimate where it falls here. The ear, we try to find where it falls there. Now the genitals, either male or female, we try to decide where it falls there. Then we're also headed with numbers. We add up the score. We put our score over here, and then we add these two numbers, and then, this is confusing. We add those two numbers, so whatever the answer is, we put here as our total score. We take that total score, and we find the closest number to our total score, and then that's how much our and then we go across, and that's how much our estimated gestational age is. So you can see how this could be very skewed depending on how you chose to score your baby. So it's just a screening tool. It's not all right. So physical assessment of your freshly born baby. One of the things I want to point out is the head. If the baby has a cephalohematoma or a caput secundum, okay? Cephalohematoma is a big bruise or blood collection, okay? And then the caput secundum is just fluid, okay? So if the baby was beaten against the pelvic bone, or if there was forceps or a vacuum extraction, something that caused a big bruise, we'll have a cephalohematoma. And then the caput is just swelling, beaten against the cervix, molding, and then swelling, okay? The important distinctions between these two, or how you can tell which is which, is the hematoma does not cross suture lines. So you remember this, we had this long suture here, and then we had this long suture here. So if I had my hematoma here, it would be within these suture borders, okay? But if I had a caput, it could be the whole area. It could cross the suture lines, okay? So here's a picture of caput. This is just the fluid. And you can see this suture line, it's crossing over it, okay? And you can't see this picture at all, but this baby has a caput, so very difficult. So here is what the hematoma looks like. It is contained in that suture line, okay? And you can kind of see this baby a little bit, this area right here. So it's staying in that suture line defined area. All right.
I have a question real quick on that. So that's the one we talked about where they would get jaundice from.
The hematoma, yeah.
Will that area also turn really bruised, or will it just kind of?
Yeah, so if your baby has a lot of hair, you might not be able to detect it. If you had a bald baby, you would see it. It would be discolored, like a bruise. Okay, so some common reflexes you want to look at with your baby. So the tonic neck reflex. So whichever way their head is looking, their arm will extend. Okay. Anytime anything goes in a baby's hand, it'll grasp, or it should grasp. The Moro reflex, which is basically the startle reflex. Clap your hand real loud, make sure baby, blah. Rooting reflex, so if you touch beside the baby's lip, it should turn towards it and even open their mouth. Stepping reflex, so if you hold a newborn up, it'll do that with its legs, act like it's trying to take a step. And then sucking reflex, if something goes in their mouth, they will start sucking on it, okay? All right, let's cover skin real quick. So acrocyanosis is the blue hands and feet. It's normal to have blue hands and feet. Usually within 24 to 48 hours, that goes away, okay? But it is so common for a parent to say, oh my gosh, is my baby okay? Her hands are really blue, or her hands are really cold and blue, okay? and it's not so much that she's cold, the baby's cold, it's just that there is poor circulation in her hands, and that makes her hands cold. What the baby is doing is shunting their blood to the vital organs here the first couple of days after delivery to make sure that all their organs are on board with this new life of not being in utero. Okay. Modeling is a lacy pattern across the skin. We'll see modeling if our baby is cold, if our baby has prolonged apnea sessions, or if our baby is septic. The Harlequin sign is really cool if you ever see it. One side of the baby's body will be red, noticeably red, and the other side will be noticeably pale. Erythema toxicum is just newborn rash, we call it most often. It's the little lesions on their skin that look like little pimples. Okay, it could be on their trunk, stomach. I've seen them on the legs, and I just tell my parents not to scrub those or pick at those. Okay, they will eventually go away, and don't put any creams or anything on them to try to make them go away. Okay, you're just gonna confuse baby's skin and cause maybe even more of a problem. Milia is the white sebaceous gland. You see it on the baby's nose most often. It's just like little white pimples. They're not raised, they're flat, but and they will eventually dissipate.
Is that what they call this baby acne?
The milia? Yeah, I mean, they're kind of baby acne, or is kind of used interchangeably with the two, with the toxicum, erythema toxicum, and the milia, okay? Because they both look like acne. All right, and the vernix is the white cheesy substance that's all over the baby's skin when they're born. The more preterm they are, the more vernix you're going to see on your baby. Okay, this vernix covered the baby in utero. It was a protectant to their skin. We try to wipe that off right after delivery, and then whenever they get their bath, we wash this stuff off. But this, don't be like taking a credit card and scraping this stuff off, okay? It's not going to hurt the baby for it to be on there, okay? And sometimes it can be a little difficult to wash off, and you would have to scrub and scrub and scrub it, and just don't do that, okay? Get it with the next bath or something. Telangiectatic nevi are basically your stork bites. Those are those little pink spots on the back of their neck or on their eyelids, and they fade pretty quickly. Mongolian spot, so that's the bluish, oh nice spelling, bluish black gray pigment of the skin. It looks like a bruise on their lower back. It could be on their buttocks, it can be on their thighs, and it can extend up their back a little bit. And you see this with dark skinned babies, and especially you can also see this with babies that had a dark parent and a white parent. Okay. So just point this out to parents so that they don't see this for the first time and be like, oh my God, what's wrong with my baby? It looks like a little bruise or a bigger bruise. Okay. Nevus flammeus is a port wine stain. It's just a bunch of capillaries right below the skin that just make that area look red for, it's just red or purple. And these are common on the face. They don't usually fade. They don't get bigger. They could mean absolutely nothing, or they could be this neurological disorder. So if you notice this on your baby's face, just point it out to the physician, and he will do studies if he feels it's an issue. Nevus vasculosus is a strawberry mark. That is a capillary hemangioma, just like a raised red moly looking thing, okay? These things can grow and they can get quite large, but when they decide to stop growing, whenever that is, 3 weeks, 3 months, even a year, then they'll start shrinking. And they could shrink and just totally disappear, or just shrink and, yeah, I know something was there at one time, okay? All right, so hard to tell on this baby, but baby has acrocyanosis. So if you look at that hand compared to their face, then you can see the difference in the coloring, okay? Here's your modeling. Can you guys see that a little bit? Okay. Can you see that Harlequin sign? Here's your newborn rash or erythema toxicum. It just looks like little pimples, okay? And then here's your milia. So this could be newborn acne as well, but it's just sebaceous glands. It's usually on their nose. It'll go away. Here's a stork bite right between baby's eyebrows and on that eyelid there. Here's a Mongolian spot. I don't know if you can see that very well. Looks like a little bruise right here and a little bruise right over the sacrum.
That's a hairy child.
Yeah. A lot of Lanugo.
Yeah, so a lot of Lanugo. And some of your dark-skinned babies do have a lot more Lanugo than others. Here's that port wine stain on the temple there. Here's your nevus vasculosus on the face. All right. So review the neuro assessment. In this part of the text, it's basically your reflexes. Your newborn's behavioral assessment, so their sleep cycles, their wake cycles. And then we're actually going to be able to breeze through this because we've covered lots of this in our lab day at the hospital. Just to review very quickly, the fundus is the top part of the uterus. Should be at the level of the umbilicus and or below, depending on how postpartum they are. But it should not be above the umbilicus. Okay, if it is, you need to investigate why. Now, this does not mean that my patient at 12 hours of age, if her umbilicus is 2 or 3 below the, if her fundus is 2 or 3 below the umbilicus, there's not a problem. Okay, this is just a typical norm, but we don't want it to be above that. Okay. Okay, here's your lochia. It's red, rubra. It's pink serosa. It's white alba. In the hospital, it'll be rubra. You may not ever get the chance to see the serosa unless you have a C-section patient and she's there for her 3rd or 4th day. Okay, but this is something you can educate your patient about what to expect. Okay, and so her uterus should be back to pre-pregnant size by the end of her postpartum period, which is about 6 weeks. You've seen this about the measuring of the fundus. I just threw this in here. Diastasis recti. This is where a woman's abdominal muscles separate. And it's pretty bizarre when you see it. I mean, it's not a big deal, okay? But it's really bizarre because if this woman doesn't have a lot of fluff, you can look at her abdomen and see the separation. It's a big ridge going up her belly. And then if you're checking a fundus and you put your fingers through that, it's kind of weird feeling. But anyways, just throwing that in to show you. So your psychologic assessments of your mom after birth. Oops. And then you guys remember the bubble he. So this is just a mnemonic to help you remember your assessment parameters on your postpartum patient that are specific to her delivery.
I have a quick question. That tear, does that put them at any higher risk of like a hernia or anything like
Well, no, because, oh shoot. So depending on, so it's not so much a tear. You've got, so we've got this ligament still connected, okay? It's just stretched. So it's not so much a tear, but if it was a tear, well, yeah, they might be at risk for some type of herniation, but
it's not standard to repair that.
no, nope.
No, it resolves.
Huh? Yep,
It resolves after pregnancy.
yep.
Oh. Okay.
All right, so your bubble heat, don't forget that. Concerns of your mother, we need to make sure we address concerns of your mother. The one thing I want to point out is when we're assessing moms postpartum and we're worried about attachment issues, okay? So if your mom has attachment issues, talk to your mom, do some investigation. It doesn't mean she doesn't want her baby. It doesn't mean she's going to abuse or neglect her baby. She might be afraid of her baby. She might not know what to do and is afraid to touch her baby because she's afraid of doing something wrong. Okay? So don't naturally assume a mother who is letting her baby lay in the crib and cry is a mother who's not wanting to take care of her baby. Okay? So go in and just talk to her. What's wrong here? What can I do to help you? And find out. Maybe she is some deadbeat mom that's not going to take care of her baby, but don't assume that right off the bat. Okay? All right. So review this section, developmental tasks of being a mother. Okay? Oh, made it. All right, so please let me know, email me if you have questions about anything, because your exam is on Sunday.
When you just about that, short of like rereading the book and going through my notes, is there any like study guide or anything in particular?
The only study guides are the PowerPoints. Now,
Okay.
I put the PowerPoints for each chapter, the full entire PowerPoint on Moodle. So you can kind of use that to run through and quiz yourself that you know what each of those things in those slides cover.
So that would be like the best study material to use
Right.
before your exams. Okay.
This PowerPoint I also put on Moodle because I don't go over every single slide. So I just put this one on here,
Okay.
and sometimes I edit this one a little
So they're
bit.
more complete.
Yeah, because sometimes there's just terms on the main text PowerPoints, and then when I've pulled those terms, I've defined them. So my PowerPoints have a little more information. Okay. No, I thought you were concerned about her, and then I saw her laying, and I'm like, facilitate that. Then you said my name, and I'm like,
On the quiz last week that I got to the question, so, I was going back and reading in the book. If a woman is at a negative station and her water breaks, she will never be ambulatory again.
no.
Okay. Because we were talking about, like helping with the labor along, and once the waters grow and they're at a negative station, they're bed rest.
So, yeah, if they're at a -2 station, if I am the one who checks them after the water breaks, and I have a lot of room between that cervix and the head, she's not getting up and walking. But if I check her and that cervix is applied to the that head is applied to the cervix, even if she's at a -1 station, if it's applied to the cervix, I am not concerned about the cord. Okay, yeah. And if it's not me that checked her, if it was the physician, say the physician broke her water, I will always clarify, is she free to get up and walk?
So if they have to be that, it's definitely most likely like straight capping them.
Or put them on the bed.
Ranking.
That's an
What's that?
I know. Isn't it cute?
Oh, so I did, okay. So, I can't remember if it's you guys or the PMs. Has anybody looked at Practice OB on ATI? No?
I don't think it's open.
Okay, because one of them wasn't even there. One of you guys wasn't even there, the other one is open, so it must have been you. So we called ATI and they supposedly fixed it. So I'll go in today and open the practice exams. So I want the practice exam done before we do the proctor. I don't really care when you do that. I am letting you know what's best for your schedule to do that practice exam. I want practice A, or practice assessment. I want practice A assessment. That's the one I want you to do, okay? You can do practice B if you want for more practice. That's fine and dandy, okay? And I think I wrote that I don't require remediation. Woo! Did I write that? If I didn't write that, I just opened my big mouth. So therefore, I do not require remediation. However, I do know that you people want to know what you got wrong and that you will go back and look that up, okay? Because that's only going to help you, and you want to do this.
On the practice, it tells you as you're taking it. Like as soon as you submit it, it
Oh,
tells
okay.
you what the answers
Gives you
and
the
rationales
rationale.
are.
Does anybody else have ATI moving incredibly slow? Like last night I did the mental health test and it took me 4 hours to complete that test.
Yeah, I did mine last night, it was pretty quick.
Of course, it has to
Same
happen
here.
during the mental health exam too.
I was just like,
I did mine too, but it was like an hour and 15.
Oh, it seriously took me 4 hours. It was unbelievable.
I think I would have given up at that point, been like,
well, I was just
All
hoping.
right, and then the other thing I want to add is please remember that after exams, I am willing to hear your comments, disagreements, and arguments about questions. If there's an exam question that you bring to my attention, and this happened in PM this last week, that the question was written wrong, that the answer was correct. So all of them got the question wrong. And I gave them full credit for that question. My problem is I read the question and say, oh, that's a great question, and then I put it on the exam, but I don't click what is the right answer to make sure that it answered correctly. I probably should start doing that. But anyways, so if it's a question like that, I will give you full credit. If it's a question that you answered wrong, no doubt about it, but you want to argue it with me, and your argument is valid, I will give you half a point for that question. So if you're going to argue with me, have your reference
only after a
ready.
duel with swords.
Oh, yeah. And then I'm going to go out and slit your tires. No, I'm teasing. I'm so teasing. Oh, shoot, that's recorded. Oh, my goodness. I cannot keep myself from getting in trouble. Good day.